Insulin. So when are we going to use insulin for diabetes? Or who is the diabetic patient who needs insulin? Of course, number one is all type 1 diabetes. Because what's the problem in type 1 diabetes? No insulin. So what's the treatment? Yes, insulin. So all patients with type 1 diabetes, they need insulin. Insulin for them is life. But also, patients of type 2 diabetes who present with very high hemoglobin A1C. Very high, by this very high I mean higher than 9%. Why 9%? Because the incidence of complications of diabetes increase markedly if your hemoglobin A1C is more than 9%. So these patients will need insulin. Also, patients who fail maximal anti-hyperglycemic therapy. You give them 2 drugs, 3 drugs, and you cannot keep their hemoglobin A1C less than 7, then this is the time for insulin. Or patients with type 2 diabetes in which the disease progressed so much that they now experience pancreatic failure. Their pancreas is exhausted, and this insulin that was coming out of the pancreas no longer comes out of the pancreas, and now they are going to be kind of insulin dependent. Sometimes patients of type 2 diabetes might need temporary rapid control of their diabetes. Like when? During times of stress, infection, hospitalized patients, psychosocial stress, you need to give them insulin. Why? Because stress will release a lot of stress hormones, glucagon, catecholamines, cortisol, growth hormone. These are the stress hormones. Stress hormones, all of them work eventually to increase the blood glucose level, and this will call for insulin. Or if your patient is starting another medication that can worsen the diabetic control, like steroids. Patient starts taking corticosteroids for some rheumatoid arthritis or other autoimmune disease. This is the time to give insulin, because you will expect it's going to be hard to control diabetes. And sometimes when you start therapy in a highly diabetic patient, you want to give this push at the start by temporarily using insulin. It's very important to realize that we categorize different types of insulins based on their pharmacokinetics. As we see in this diagram, we have the rapid-acting insulin, the short-acting, the intermediate, and the long-acting insulin. So this table summarizes the differences in the pharmacokinetics of these medications. The rapid-acting insulin, insulin aspart, insulin lispro, these work very fast. Within 10 to 15 minutes, this insulin is going to work, and it covers the insulin needs for meals eaten at the same time of injection. And if your patient is using these insulins, you have to warn the patient that in 15 minutes, if he does not eat, he's going to collapse because of hypoglycemia. Very, very dangerous. So better to take the first bite of food and then take this insulin. Never take it if food was not in front of you. Short-acting insulins, the regular one. This is the regular one that we use in hospital for hospitalized patients. The regular insulin, Humulin R or Novolin R, these insulins start working within 45 minutes, and they cover 6 hours. So they usually cover insulin needs for meals eaten within 1 hour. Intermediate acting insulin, the NPH, Humulin N or Novolin N, they usually cover up to 12 hours or even more. So they cover insulin needs for about half the day or overnight. Finally, the long-acting insulin detamir, insulin glargine, they cover the whole 24 hours. So they cover insulin needs for about 1 full day. And we have another type of insulin called pre-mixed insulin, where we mix, it's a combination of the intermediate acting together with either the rapid acting insulin or the short acting insulin. And usually we refer to this pre-mixed insulin by 2 numbers, like Humulin 70-30. Usually the first number is going to be referring to the NPH, and the 30 will be referring either to the regular insulin component or the rapid insulin component. How to administer insulin? Of course, subcutaneous injections, preferably in the abdomen. Do you know that there is an inhalational insulin? You can give insulin by inhalation. Exubera was the first inhaled insulin that was tried long time ago, not long time, few years ago, but the inhaler was so bulky to be used. And recently they released a Freesia. A Freesia is a very handy device that you can administer inhaled insulin with. Still, it has not gained so much popularity, and still the basic technique of administering insulin is by subcutaneous injections, either by the vial and syringe or by the prestigious pen device. How about insulin pumps? Insulin pumps, these are kind of applied inside the patient. You apply them subcutaneously, and they deliver, what is the type of insulin used in insulin pump? Rapid acting insulin. And they deliver a basal dose that is of insulin that is pumped continuously to deliver a basal rate of insulin, and they deliver also bolus doses pumped to cover meals or to correct high blood glucose level. What are the different insulin regimens? I'm not going to go into details, but here are the 3 insulin regimens. Number 1, basal. There is a common saying in managing diabetes by insulin: fix fasting first. Fix the fasting blood glucose level first. And in order to fix the fasting blood glucose, in order to keep the fasting blood glucose within your target goals, you have to use the basal insulin regimen. And you can give insulin either once daily or twice daily. If you're going to use insulin once daily, usually in the evening, you have to supplement it with an oral medication. If you're going to give insulin twice daily, you do not need to supplement it with any other medications. This basal insulin regimen, what does it control? It controls the fasting blood glucose. But what if the patient has a good fasting blood glucose, but he only shows increased blood glucose following meals? Then you need to keep giving the patient this basal insulin dose, and you need to add another bolus dose each time the patient eats. And this is the basal bolus or prandial insulin regimen. Finally, the sliding scale or the correctional, where you give insulin in response to the patient's blood glucose level. This is the technique followed in hospitalized patients, and we give short-acting insulin or the regular insulin for these patients. Insulin side effects. The most important side effect of insulin is hypoglycemia. Hypoglycemia, very dangerous. How can we see it? A patient who takes insulin and does not eat. A patient who takes insulin and does not eat is going to suffer of hypoglycemia. Weight gain. Remember, insulin is a lipogenic, is an anabolic hormone. It adds weight to your body. So you have to watch your diet, you have to watch your weight before using insulin or during using insulin. Lipodystrophy. Remember, insulin is a lipogenic. It can make you fatty, or wherever you inject it, it's gonna deposit fat in these areas. So if you don't rotate the sites of insulin injection, as in this patient used insulin in 2 fixed points in his abdomen, on the right and on the left, and here we have lipodystrophy. We have abnormal accumulation of fat in the points of insulin injections, and that's why we always advise our patients to rotate the site of insulin administration.